Welcome to this educational activity where Dr. Nancy L. Kuntz from the Ann and Robert H. Lurie Children's Hospital of Chicago and Northwestern University Feinberg School of Medicine discusses advances in the treatment of spinal muscular atrophy within the context of a patient and his parent who are beginning their therapeutic journey. The following audio is part of a certified educational activity titled A Patient's Journey from Diagnosis to Treatment, a story on the transformative impact of precision medicine on spinal muscular atrophy management. Access the entire activity and complete the post-test at www.peerview.com/ACD. Downloadable slides and practice aids are also available.
Today I'll be discussing the identification, diagnosis, and treatment of spinal muscular atrophy, or what we'll call today SMA. SMA, as you probably know, is a disorder characterized by development of progressive weakness and is associated with autosomal recessive inheritance. There is a spectrum of severity from onset in infancy through adult years. Symptomatic infants may not live beyond several years of age without very aggressive respiratory and nutritional support, but individuals with onset in adult years have a normal lifespan with weakness and limited mobility, leading to decreased function in their later years. SMA continues to represent the leading genetic cause of death in infants. There's an incidence of approximately 1 in 11,000 live births across all ethnic groups. The carrier frequency has been observed to vary between 1 in 40 individuals to 1 in 67 individuals in different ethnic groups. SMA, we now know, is caused by absent function of the survival motor neuron gene, which is located on chromosome 5q13. This is usually a deletion. However, a point mutation can also cause the gene to lose function. Without the function of the SMN1 gene, there's an SMN protein deficiency. And we recognize now that that leads to abnormalities in RNA splicing. Human beings, however, have a gene paralogous to SMN1, which has been termed SMN2. This produces a very small amount of functional SMN protein, as we'll see in our later discussions. So the SMN2 copy number has been recognized recently as a major modulator of the phenotype, the clinical phenotype of SMA. I'd like to share a patient story with you. Aiden was the first child born to healthy, non-consanguineous parents. He was born at 38 weeks gestation, weighing 8 pounds, 2 ounces. Gestation was uncomplicated, and routine prenatal screen on mother, who is a 24-year-old prima gravida mother, were all normal. Labor was unremarkable, and after an uncomplicated delivery, APGAR scores were 7 and 9 at 1 and 5 minutes. Aiden began breastfeeding without difficulty, was discharged home with his mother on the second day of life, and subsequently, his routine newborn screening tests returned with normal results. Parents were delighted. During the first 6 months of life, Aiden's development was normal. He was alert, he tracked visually, he developed a social smile and began cooing and babbling on schedule. He developed good head control and began rolling from front to back and vice versa. By 6 months of age, he began to sit without support. However, over the next 6 months, Aiden's mother noted that further motor milestones were not being met on schedule, as she observed in her baby book. Aiden's sitting posture and head control looked more slouched. Despite adequate play time and tummy time, Aiden was not noted to push up onto his hands and knees. He was not beginning to crawl. He did not bear weight or bounce when he was placed in a standing position by his mom. By his first birthday, Aiden was not standing or attempting to cruise, and this alerted Mom. During Aiden's 1-year checkup, his mother said she was worried about his slow motor development. Observing Aiden, the pediatrician noticed that he was sitting independently but with less confidence than had been observed on previous visits. On his examination, Aiden was alert. He babbled actively. He used mama and dada in a very specific fashion. He recognized his name. He used a fine pincer grasp to pick up small pieces of food and feed himself. However, he would not bear weight when placed in a standing position. and it seemed as though his truncal or axial tone was decreased. Muscle stretch reflexes could not be obtained over the quadriceps or biceps tendons by the pediatrician. However, face movements and extraocular movements appeared normal. Aiden's pediatrician agreed with mother and expressed some concern about the motor development, and noting that the motor development seemed to be slower with other aspects of development like receptive and expressive language and fine motor skills being much stronger. So a decision was made to refer Aiden to a pediatric neurologist. At the pediatric neurology consultation, the neurologist found mild to moderate hypotonia, agreed that there were absent muscle stretch reflexes. There was muscle weakness. With respect to shoulder movement, Aiden was able to reach up toward his mother, but it was easy to overcome the strength of that movement. In his lower extremities, it was noted that he could raise his heels or his legs off of the bed against gravity with his hips flexed, but he was not able to lock his knees or push back when he was placed in a supported standing position. He was noted to actively dorsiflex his ankles and to extend his wrists. He was noted to drool occasionally, but he was teething, and so it wasn't clear whether that was part of the teething or, in fact, was any aversion to swallow. No tongue fasciculations were observed. Facial expressions appeared full, and extraocular movements were normal and full. Aiden's alertness and responsiveness appeared normal for age. He demonstrated object permanence, used mama very specifically for his mother, recognized his own name, and used a beautiful fine pincer grasp to pick up small objects. And this led the neurologist to consider what the differential might be for this child. It appeared again, large muscle motor weakness was the prominent finding, with other aspects of development, including language, responsiveness, and fine motor skills being much stronger. As neurologists, we're all aware that the differential diagnosis of muscle weakness is really quite broad. You can look at the entire neuroaxis and find ways of explaining muscle weakness. This goes from upper motor neuron problems within the brain or spinal cord, all the way to the many parts of the motor unit, from the lower motor neuron through the peripheral nerve, the neuromuscular junction, and muscle, that all can have flaws and abnormalities that will cause muscle weakness. So I would have to say that the most striking findings in summary with respect to Aiden's neurologic examination is that he has large muscle motor weakness in a non-uniform fashion, affecting primarily proximal girdles. The face is spared. He has very difficult to elicit or absent muscle stretch reflexes, and no upper motor neuron signs. Given all of this, I think it is much more likely that the motor neuron or muscle, maybe secondarily, might be affected. Neurologists have obviously been describing and treating SMA for many years, many generations. And it's only been within this generation that the specific gene that is causative for spinal muscular atrophy has been identified. Again, I mentioned it's been termed SMA1 and is located on the 5th chromosome. However, in humans, there is relatively similar SMN2 gene. The single base difference has a profound functional impact. It prevents inclusion of exon 7 in the read-through of the RNA most of the time. So some of the time, maybe 10%, around in that region, read-through of SMN2 will produce a functional, stable, full-length SMN protein. However, the rest of the time, the smaller, truncated, unstable protein that is produced becomes rapidly degraded and non-functional. The pattern that has been developed for testing when one clinically suspects spinal muscular atrophy is to do the targeted testing for the SMN1 gene. If there is a homozygous deletion of both copies of exon 7 on the SMN1 gene, the diagnosis is made and you don't need to go any further. However, in small numbers of infants with early onset, but maybe up to 5% of older infants and children and adults with SMA, they lack complete function of the SMN1 protein due to a compound heterozygote state. where they have one absent and one non-functioning SMN1 gene. The ways that people look for the SMN1 gene would show that as a negative test, meaning that they don't lack both copies. So what is necessary when you have a patient with very high clinical suspicion for spinal muscular atrophy and they did not lack both copies is to count the number of copies of SMN1. And in fact, if they have one existing copy, and the way this is tested is frequently called a carrier test, the individuals would have an absent copy and then a non-functioning copy, probably due to a point mutation on their single existing copy of SMN1. Historically, SMA has been classified into different groups. Before the gene was identified, it wasn't even perfectly clear whether these were completely related disorders or whether they might be due to different types of physiology. However, once the gene was identified, people were tested and it became clear that what had been called SMA type 1, infantile-onset, usually before 6 months of age, with very severe hypotonia and weakness, and sometimes referred to as Wernicke-Hoffmann disease after the neurologists who described it first, had the same homozygous deletion of SMN1 gene that older children who had the ability to walk independently but then had motor regression occurring later in their lifetime and who had been referred to as SMA type 3. It's becoming much less important to categorize children with SMA by this fashion because the natural history is being rewritten. We now have treatment available, as we'll discuss, for spinal muscular atrophy, and this will affect the prognosis of all children, depending on not only their pre-existing genetic phenotype, how many copies of SMN2 they have, for example, but also on whether they get treatment and at what point in time in their life this is presented. My approach would be to use a first tier of testing, and in this circumstance, what I recommend is that a blood test, creatine phosphokinase, CPK muscle enzyme, be sent along with blood to test the SMN1 gene. Many times these days they will also add how many copies of SMN2 are also present. This approach was done for Aiden and showed that he had a mildly elevated creatine kinase. It was elevated between 1 and 2 times the upper limit of normal. Again, this is not normal, but it's a very nonspecific finding. It could still reflect a muscle disease, or it could be compatible with spinal muscular atrophy. And when after 1 to 2 weeks, the SMN gene test became available, a homozygous deletion of SMN1, including the exon 7 on both copies, was noted. So, given this, and looking back to Aiden's story, the question is, what would we historically have classified his type of SMA as? Clearly, he was able to sit independently, but at least to date, was losing motor skills without the ability to stand independently or walk. He had onset after 6 months of age clinically. He was demonstrated to have a homozygous deletion of SMN1, and when his SMN2 copy number came back, it was 3 copies. And all of these things would fit together to have him be an intermediary form or an SMA type 2. When the diagnosis is made, this is always a very emotional time. They need to both absorb the diagnosis and some information about the untreated natural history and complications. All of the individuals who have spinal muscular atrophy have a number of complications that present during their lifetimes. And the severity of these complications is completely related to the severity of the spinal muscular atrophy or the deficiency of SMN protein. These complications fall into several different categories. There is respiratory muscle weakness, particularly of the chest wall, with individuals with severe SMA depending primarily on use of the diaphragm muscle for their ventilation. This can lead to respiratory failure chronically, particularly or first being noted during sleep when everyone breathes somewhat more shallowly. It can lead to atelectasis and recurrent infections, And so respiratory issues are very important and part of what you discuss with the family. Nutrition is also a very important issue. The bulbar muscles, the chewing muscles as well as those used to swallow, are weak, and this leads to a risk of aspiration with subsequent pneumonia and lung disease. It also leads to usually decreased intake as the individuals with SMA intuitively decrease the speed and volume of food and liquid intake to protect themselves and protect their airway from coughing and gagging and aspiration. And then the obvious major final area of complication in spinal muscular atrophy leads to the decreased mobility, the decreased ability to ambulate when one is weak. The decreased strength in trunk muscles leads to potential for curvature of the spine and vertebra into scoliosis, which can then have negative impact on respiration. What we find in these very young infants who don't stand, bounce, walk, or run is that from a very early age, their bone density is below fracture threshold and they're at risk for fractures and complications of that. Thankfully, there are family support groups that have worked very hard to make parent and family-friendly educational materials available, which I think is a very good idea for all of us to make available online or in print to the families after we review this exhausting list of information that we can provide them about the natural history and complications of spinal muscular atrophy. Because I can assure you that only a small fraction is absorbed one time through. They need to both absorb the diagnosis as well as be supported in processing their grief and then move quickly into understanding and getting information about the potential treatment that is now FDA approved and possibly in the near future availability of other clinical treatment trials that may be pertinent to their child so that they can make some important decisions about their child's health. Another thing that needs to be attended to at this very, very busy time is providing genetic counseling for the parents and their relatives. With or without additional treatment directed toward the cause of disrupted pathophysiology in spinal muscular atrophy, it's important to make a referral to a multidisciplinary clinic. Nutritionists, physical therapists, occupational therapists, metabolic bone health specialists, orthopedists, pulmonologists, ICU teams that can support infants through many, many types of respiratory illness. And so to be able to not only make the diagnosis, but to quickly identify a multidisciplinary clinic that could support the families is very important. I can't emphasize enough how complicated the specialty care can be that children with spinal muscular atrophy benefit from. There are devices that can provide cough assist, that provides positive pressure followed by a suction that gets mucus and drainage up. This is something that many children with spinal muscular atrophy have adopted as part of their daily routine. Frequently, other types of things, vests that vibrate and shake the chest, cupping and physical percussion of the chest. Overnight polysomnography can be done to determine when children might need positive pressure or BiPAP provided to them at night. Winter is frightening to me as someone who cares for a lot of children with spinal muscular atrophy because we have children who have not yet developed immunity to respiratory syncytial virus, who are susceptible to influenza and the whole panel of respiratory viruses that are out there. In addition, there are a lot of steps that can be taken to provide and improve nutrition in children with spinal muscular atrophy. But the two things that become important are evaluating the swallowing mechanism to see if there's any risk of or occurrence of aspiration, whether modifying the food texture or consistency would affect that, and whether there's any gastroesophageal reflux, because all of those make a difference in terms of how you might most efficiently support a child to get adequate nutrition. With the very youngest of the infants, who frequently, because of their low tone throughout the trunk, and the need to position them in a manner that will not crowd the diaphragm. If they do have gastroesophageal reflux, it tends to be rampant. So consideration of a fundoplication to try to decrease or minimize the reflux. But a gastrostomy tube placement with or without the fundoplication is frequently something that's offered to infants when it's felt that they'll have long-term problems with nutrition, particularly fluids. Nasogastric tubes or nasojejunal tubes can, on a temporary basis, provide adequate fluids and nutrition. The difficulties is that those can become dislodged. We then get back to the issue that frequently led to the diagnosis to begin with, and that is that the children with SMA are less mobile. The field is changing all of the time. We now have lightweight, sporty wheelchairs that don't require much training and really can allow the children to bob and weave on the playground with their peers. There are powered, joystick-controlled wheelchairs. Children with spinal muscular atrophy learn very well, have normal needs for learning, exposure socially, exposure educationally, and so it's very, very important that they not have to face the choice of expending their entire day's worth of energy to get across the room to investigate that butterfly, or save it but miss out on the learning opportunity. It's also very, very important, as I mentioned, it is through the first several decades of life that bone mineralization occurs, and this requires evaluation of the diet, the calcium and the vitamin D intake, as well as promotion of weight bearing through long bones, whether that weight bearing occur on the knees in a tall kneel, or in standing, or in gait trainers that allow weight bearing. Children can develop scoliosis. Once this begins, it tends to be progressive. There are times when bracing and careful positioning can minimize that. But there are other individuals where the scoliosis progresses to the point where it becomes critically necessary to arrest the progression of the curve to prevent problems with the bellows function of the lung in children who already have compromised breathing. So spinal fusion used to be the only option. There are now surgeries to stabilize the spine that, rather than fixing the entire vertebral column to the pelvis, attach to some of the upper ribs and lower ribs and allow for either manual or magnetic extension of the rods between them. They're frequently called growing rods and work well in children with spinal muscular atrophy. Nusinersen is a synthetic antisense oligonucleotide that is very specifically targeted toward the part of SMN2 that is altered to make it difficult to include exon 7 in the read-through. It sort of suppresses the abnormality and allows virtually 100% read-through with copies of SMN available. It has been given intrathecally. It does not have an infinite half-life. Loading phase of treatment over 2 months is now followed and recommended to be followed by maintenance intrathecal dosing every 4 months. And the FDA has approved it for persons with spinal muscular atrophy, infants and children and adults. The last 2 years have seen a number of very carefully done clinical treatment trials looking at the effectiveness of Nusinersen, or this synthetic antisense oligonucleotide. The two major ones were ENDEAR and CHERISH. ENDEAR was a multi-center international trial of 120 or so infants who had clinical onset of spinal muscular atrophy with genetic confirmation prior to 6 months of age, but not within the first month of life. They had 2 copies of SMN2 gene, none of SMN1. These were infants who also were asked to be adequately ventilating with normal oxygen saturation during wakefulness and sleep at room air at the time the trial began. And then there was a randomized, double-blinded study where 2/3 went into the treatment arm and 1/3 went into the sham procedure control arm. Obviously, children were enrolled in a rolling fashion across these 30 sites internationally, depending on when they presented and were evaluated. So the planned interim analysis occurred when 2/3 of the children reached 6 months of observation, which would have been the loading phase and the first maintenance treatment. It was shown that with the primary outcome being motor milestone progress, as manifest by the repeated administration of a Hammersmith infant neurologic examination, that 41% of the infants in the treatment group had improved, and none in the control group had improved over that period of time. There was also an assessment later on of long-term outcome, event-free survival, meaning not only survival, but also surviving without needing at least 16 hours a day of mechanical ventilation and respiratory support. When that was analyzed at the end of the study, the number of children who had survival was statistically much greater in the treated group than in the sham procedure control group. And this was ENDEAR, the trial relating to infants with onset of SMA, or what we used to term the SMA type 1 infants. The other trial that I mentioned to you was termed CHERISH, and this was again very similar. There were again 30 sites internationally, and about 120 children between 2 and 12 years of age were enrolled in the study, and they had to have genetically confirmed SMA. None of them had onset of clinical symptoms before 6 months of age, and there were some criteria about not having mechanical problems in terms of contractures or scoliosis that would limit gaining any motor skills if you improved with respect to strength. And again, the outcome measure that was planned was looking at changes in motor function as measured by the Hammersmith Functional Motor Scale in the expanded version. And then when this reached the pre-specified interim analysis again, there was a very significant difference with much greater motor gains in the group that was treated as compared to the control group, which actually had a small decline in their motor skills. Also very encouraging about this treatment is that it appeared to be very safe. There were no significant adverse events that appeared to be related to the treatment itself. It's important to recognize that Nusinersen is not the only scientific translational effort being undertaken. Specifically, there's been a pilot trial at a single site in Ohio where 15 patients with spinal muscular atrophy type 1 had a safety and dose escalation study using a gene replacement scheme. For these infants, an AAV, or adeno-associated virus type 9, was created. Was built, the capsid was stripped of all of its native agents, and a synthetic SMN1 gene was placed inside that capsid. This was given in very large doses intravenously to these children. The first 3 received a lower dose, and when that was well tolerated, with some change in liver functions and need for temporary immunosuppression, but resolution of the concern, the next 12 infants were treated with higher doses. And particularly the last 12 who were treated with higher doses intravenously of this gene replacement have done amazingly well. Unlike the natural history where most children with early onset would be unable to survive past 2 years of age without respiratory support, this small cohort of children have not required respiratory support. A good fraction have been able to feed orally, although some are receiving tube supplementation, and they are gaining motor milestones, with some of them beginning to walk. This has led to a lot of excitement, and additional trials are being planned, both for infantile-onset spinal muscular atrophy with intravenous administration, as well as with toddler-aged children who are sitters who will be treated with intrathecal gene replacement. There are a number of other ways that people have tried to look at therapy for spinal muscular atrophy. There are some less targeted but oral agents that have been identified as antisense oligonucleotides. that would modulate the ability of the SMN2 gene to produce effective SMN protein. These have been done more in Europe than in the United States. There were some safety signals that led to pausing and regrouping and improvement of some of these agents. It's way too early to comment on the effectiveness of this, but clearly any change toward oral therapy would be greatly beneficial to the group of children with SMA. So we'll have to wait to see how this works. There have been some other attempts to use neuroprotective agents such as oleoxacin. This was studied primarily again in Europe and in older children with some promise, but not meeting the primary endpoint that had been identified. So exactly when those trials might be refined and restarted is not clear. There are also some agents used in spinal muscular atrophy that are not targeted directly toward the mechanism or pathophysiology of spinal muscular atrophy, but are agents which might generically enhance the function of nerve or muscle. So for example, some agents that improve the contractile mechanism and produce more force with the same amount of effort are being trialed in spinal muscular atrophy. Agents that improve the neuromuscular transmission, like pyridostigmine or 4-aminopyridine, are being trialed. Most of these trials have been directed toward older individuals with spinal muscular atrophy. Aiden's story demonstrates very clearly that genetic testing can facilitate the diagnosis of spinal muscular atrophy. It also highlights the evolving changes in the supportive and specific treatment of spinal muscular atrophy. Until very recently, the only treatment available to individuals with spinal muscular atrophy was symptomatic. Now there is an FDA-approved treatment, intrathecal Nusinersen, which is directed toward the cause of spinal muscular atrophy. There are clinical trials which have been accomplished demonstrating that the earlier this treatment is instituted, the more effective it has been in allowing individuals with spinal muscular atrophy to gain motor milestones. This information has been very, very helpful as the President's Committee on Newborn Screening Practices addresses the recommendation about inclusion of spinal muscular atrophy on the uniform screening panel for newborns. We anticipate that following some of the individual states that have already started screening, that widespread or universal screening for newborns is very likely to occur within the next several years. It's also clear that there are a number of other potentially therapeutic approaches that are being evaluated and that we hope move in translation from the lab to clinical trials to see whether some combination of therapies or some individualized difference in therapy depending on the phenotype or the genotype of SMA will be appropriate in the future. In summary, early diagnosis and quick provision of SMN-enhancing therapies is critical to improving outcomes in patients with SMA. This will be very exciting several decades ahead of us.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/ACD. This activity is supported by an educational grant from Biogen.